Okay, so good evening, everyone. I welcome you all for the FMG July 2023 recall session of ophthalmology. So I just hope before starting this session that all of you are satisfied with the performance, with the questions you got in all the subjects and especially in ophthalmology. You are satisfied with your performance, with the type of the questions you are being asked. So now we'll take a quick recall of the optional session. This is not going to be a long video. We are not going to discuss the topics in detail. We are just going to give a quick revision of what the questions are, what the appropriate answers are, and why the other three options are not the options. So actually, since this is a recall session, I was not able to get all the questions fully, not the full options, not the exact statement, but with the information which we are being provided, we'll try to solve the questions. Okay, so let us take a quick recall of the OPHTHAL. So the first question is a patient who works in an iron factory presents with visual disturbances and is found to have iron deposits in the eye. Which of the following condition is most likely responsible for this? So this is a very self-explanatory, for the diagnosis of siderosis bulbi. I hope all of you will agree that siderosis bulbi, because there is in the question there is option of iron factory, iron deposits in the eye. Okay, so what is siderosis bulbi? Just let us take a quick revision of that. Siderosis bulbi is nothing but a chronic pigmentary degenerative disease. Okay, it is a chronic pigmentary degeneration whenever there is impacted iron intraocular foreign body. Okay, this is fine. This is a normal definition what we learn about siderosis bulbi. Now siderosis bulbi affects different parts of the eye. They can be affected in this. It can lead to deposition in the cornea. It can lead to depositions in the iris. So the corneal depositions will be there. Iris pigmentation will be there. There will be deposition over the lens, and it can also affect the retina. So in retina, we always see what are the symptoms we get in retina. So the most common finding is seen to be vitreous hemorrhage, and also we can see the retinal detachment. Okay, due to the electrolyte disturbances, these are the symptoms which lead to finally the retinal degeneration in the form of retinal detachment. That is the late stages of the siderosis bulbi. So a very direct question, and the answer to this becomes the siderosis bulbi. The other options, KF rings, we know that what are KF rings? They are the golden brown deposition of the copper in the decimate membrane seen in the Wilson's disease. Okay, where there is more copper and there is deficiency of the celluloplasmin. Sunflower cataract, again, this is a finding of Wilson's disease. In this, sunflower cataract is a very characteristic type of cataract seen in the Wilson's. Okay, so these both are the options of the Wilson disease. Fourth option, I was not able to get it. So these are the three options, and this gives the answer to the siderosis bulbi. Okay, I hope all of you are clear with this. And this I have attached a picture of the siderosis bulbi. Here I hope you can appreciate this pigmentation in the corneal layers. You can appreciate the cataract. There is a deposition of iron in the lens leading to cataract, and which type of cataract is seen is mostly anterior subcapsular cataract, which is seen in the siderosis bulbi. Fine. So the next question. Next is a patient of HIV with low CD4 count presents with the following findings. So this is an image-based question, and from the image, a very characteristic image of cheese and sauce retinopathy. I hope all of you were able to identify this image of sauce and cheese retinopathy, where you can see flame-shaped hemorrhages. You can appreciate the superficial exudates, and they are mostly present around the vascular arcades. So this is sauce and cheese retinopathy, seen where? It is seen in CMV retinitis. Also, the question gives us hint about that the patient is of HIV and patient has low CD4 count. We know that in HIV, most common opportunistic infection is the cytomegalovirus, and which happens when CD4 count becomes low, that is less than 50. That is most commonly when CMV infection is seen. Okay, but the question was not the finding or the diagnosis, but a step further, that was the treatment. So, what is the treatment of the CMV retinitis? So, the treatment of CMV retinitis, the first line treatment becomes the tablet Valganciclovir. So, first line of treatment becomes the tablet Valganciclovir. But the treatment of choice to this becomes the intravitreal ganciclovir. Treatment of choice becomes the IV intravitreal. IV means intravitreal ganciclovir. It is also given, initially it was given intravenous also, but because of the increased side effects, it is given intravitreally ganciclovir as the treatment of the choice. And here, out of these two options, we were given only the one option, that was the ganciclovir. So the option becomes this ganciclovir automatic. Okay, so it is intravitreal ganciclovir as a part of CMV retinitis. Another picture I wanted to show you of CMV retinitis is, one is sausage cheese retinopathy, which is a common finding. Another is this. I hope if you do not know this, then you can add it in your notes. Notes is frosted branch angiitis. This is frosted branch angiitis, where you can see exudation along the vessels, where you can see the exudation along the vascular arcades, also seen in the CMV retinitis with the name of frosted branch angiitis. This is sausage cheese retinopathy. Okay, superficial hemorrhages and exudates. And this one is the frosted branch angiitis. Again, a picture of CMV retinitis. But most of the times, whenever this question has been asked previously also, there is some sort of history given, either CD4 count or the patient, or a known patient of HIV, which gives us a hint of CMV. Okay, so I hope again this was an easy question. So let us come to the next question. A known hypertensive patient presents with decreased vision. On fundus examination, there were cotton wool spots and flame-shaped hemorrhages all over the retina with generalized narrowing of the vessel. Which grade of hypertensive retinopathy is shown? So they have asked us about the grading of the hypertensive retinopathy, and the commonest grading of the hypertensive retinopathy which we study is the Keith-Wegener's grading, that is the Keith-Wegener grading of hypertensive retinopathy. What this Keith-Wegener grading states, in stage 1 or the grade 1 of this retinopathy, there is generalized attenuation of the vessels, there is generalized narrowing. Okay, there is generalized narrowing. Grade 2 is the focal narrowing or the focal attenuation of the vessels. And here, stage 2 is the stage where we see all the arteriosclerotic changes. All the arteriosclerotic changes. Like, what are the arteriosclerotic changes? We see the AV nipping, we see the Salu sign, Gunn sign, Bonnet sign, all these signs which are related to the arteriosclerotic changes, they are seen in the grade 2 hypertensive retinopathy. Grade 3 hypertensive retinopathy is actually, the grade 1 is generalized attenuation, grade 2 is focal narrowing plus 1. Okay, in Keith-Wegener, we always say that grade 1 is generalized attenuation, grade 2 is grade 1 plus focal narrowing, grade 3 is grade 2 plus flame-shaped hemorrhages and cotton wool spots. And the grade 4 becomes grade 3 plus papilledema. And it is a type of grade 4. Whenever there is grade 4, it is considered as a hypertensive hemorrhage. So grade 4 is grade 3 plus papilledema. So in this question, we were given, there were cotton wool spots and flame-shaped hemorrhages. It means the grading becomes grade 3. The grading becomes the grade. So this is heat Wegener grading of hypertensive retinopathy. Fine. So the answer to this question will become option number C. Next question is most common intraocular malignancy in adults. Okay, fine. So this is a one-liner questions. These are some of the questions in every subject. I feel there will be a part of the questions which will be one-liner questions. Fine. So in my opinion, what I believe is they are type of difficult questions, because if you know them, you got the full mark. But if you do not know them, you cannot apply your clinical knowledge and everything if you have not revised them. So these type of questions are like all or none phenomenon type of questions. If you have read them, it's fine. If you have not, you cannot take a guess. So these types of questions again become a very important whenever we talk about the marks which we get in the exam. So they are also one of the important deciders in the examination. Clinical questions, they can be tougher ones, but if you have attended your clinical postings well enough, you will be able to solve them. So in my opinion, there is no worry to be afraid from the clinical based question, but these one liners, because you have to revise them for sure. There is no other way to crack that. So this is just an example of that type of question, that is the most common intraocular malignancy in adults. So let us quickly make a table to quickly make you revise. So if we talk about, first we'll talk about the intraocular, and okay, let us make a table like this way: intraocular and intraorbital. Fine. In intraocular, we'll again divide it into children and adults. Fine. So in children, the most common intraocular malignancy is retinoblastoma. Retinoblastoma. In adults, it is actually basically secondaries, that is the metastasis. But if we talk about the primary malignancy, that will be a choroidal melanoma. That will be a choroidal melanoma. Okay. When we talk about intraorbital, we'll again divide it into whether it is a benign tumor or a malignant tumor. Okay. Again, we'll divide it into children and adults. Children and adults. Fine. So, most common intraorbital benign tumor in children is capillary hemangioma. This is just a division, and in adults it is cavernous hemangioma. I just hope all of you know this. This is just I'm giving a quick revision. Okay. And in malignant, intraorbital in children becomes the rhabdomyosarcoma. Fine. And in adults, the intraorbital most commonly becomes the non-Hodgkin lymphoma. Okay, so this is the table you must know, because these questions, they have been asked in NEET-PG also. So the retinoblastoma and secondaries, intraocular, intraorbital, benign and malignant, again divided into the age groups: hemangiomas, rhabdomyosarcomas and non-Hodgkin lymphoma. So if we come back to the question, it was most common intraocular and in adults. So the answer becomes MET or choroidal melanoma. The options are retinoblastoma, no, choroidal melanoma and uveal melanoma. If both were the answers, we have to tick mark the choroidal. If you will say that choroid is a part of uvea, but uvea is a general term, no? We have to tick mark the specific part. So it will not be uveal melanoma. Okay, if there is no option of choroidal, then we can mark it uveal melanoma, because choroid is part of uvea. But if the option is given as choroidal melanoma, you have to tick mark that only, because uveal or the uvea is a generalized term. It has 3 parts. So we have to narrow down it to the main organ which is involved in the adults as the primary tumor. Okay, so the answer to this question will become choroidal melanoma. Next is not the full statement of the question is available, only 3 words, and I think they are sufficient for the diagnosis: child plus jaundice plus oil droplet cataract. Even the last word is enough: oil droplet cataract, or even the image base if it was there. it is enough for the answers. So oil droplet cataract, we know that it is seen in galactosemia. It is seen in galactosemia, seen in the galactokinase and G-code deficiency, galactosemia. That is a oil droplet cataract. And one thing what we discuss about galactosemia, in initial stages, it is a type of a reversible cataract. It is a type of a reversible cataract in initial stages. So oil droplet cataract comes in the category of reversible cataract. Otherwise, all types can be are the irreversible types. So galactosemia, oil droplet cataract. Now there is another sign which we should revise is, again, is there is oil droplet sign in cornea. Okay, that is seen in keratoconus. I hope everybody remembers keratoconus. One thing important again, it is seen in cornea. In keratoconus, how it is appreciated on distant direct ophthalmoscope. How is oil droplet cataract diagnosed? It will be diagnosed on slit lamp examination, cataract. While this oil droplet sign in keratoconus seen in cornea is diagnosed on distant direct ophthalmoscopy. So these are the two oil droplets which are seen. So next question will be, patient presents with visual loss in the right side of the left eye, okay, and right side of the right eye with preserved central vision. Okay, now this question is asked in every exam every year. So this is, kind of favorite questions in the opthal which are asked in one way or the other. They are asked without any fail. They are asked. INISVP, NEET-PG, FMGE, everywhere. Okay, so it means that a visual pathway diagram should be imprinted in your mind, and you must not forget that. But if you are well versed with this question, you need not to even revise that diagram. You can answer this question in seconds by just reading the language of the question. So this question says visual loss in the right side of the left eye and right side of the right eye. Okay, so this means the same side, right side of the left eye and right side of the right eye. It is same side, that is the same side of the visual space. What is same side of the visual space? It is homonymous. It is homonymous, and we know that homonymous hemianopias, they are seen below the optic chiasma from the optic tract onwards. From the optic tract onwards, all the lesions are homonymous. In the optic chiasma, the lesion is heteronymous because they are in the opposite side of the visual space. If you want to solve it with the help of diagram, we'll do that. It also left side, left eye, right eye. Okay, this I can say this is the left side of my left eye, right side of my right eye, left side of the right eye, right side of the right. So the affected area is the right side of the left eye and right side of the right eye. Now can you appreciate it is same side of the visual space? Same side means homonymous. Homonymous are from the optic tract to optic till the end of occipital lobe. Now there is another clue in the question is there is preserved central vision. Okay, so preserved central vision is seen in occipital lobe. Why? Because the macular area is supplied by middle cerebral artery, rest is supplied by the posterior cerebral artery. So in the lesions of the occipital lobe, there will be macular sparing, and macula is responsible for what? Central vision. So the answer to this question becomes homonymous hemianopia with macular sparing. Why not heteronymous? Because they are on the same side of the visual space. I hope this image is imprinted in your mind and you will never answer this question wrong. Optic chiasma, heteronymous, that is bitemporal hemianopia. Below this, all are homonymous. Okay, some or the other pictures changes, whether it is hemianopia, quadrantanopia, it is macular sparing, non-macular sparing. So these things will change, but the side of the visual space will remain same. Okay. And this is an image to just to give you a pictorial memory why macular sparing is seen in the occipital lobe, because it is supplied by middle cerebral artery and posterior cerebral artery both. So there is ischemia of the posterior cerebral artery, there will be macular sparing, so the vision will be well preserved in the macular sparing. Fine. Next question is, a patient with a history of eye trauma, okay, with vegetative matter. This word gives us the answer. Still, let us read it further. The causative thing under the microscope is seen as septa, the hyphae, and at an acute angle. What will be the diagnosis? So we know that we need not any options for this question. Okay, so the answer is the fungal corneal ulcer. In cornea, fungal corneal ulcers remains to be one of the favorite topics, in the cornea. Okay, asked in every exam. Just like visual pathway defects, fungal corneal ulcer is also favorite topic. And we always study the differences between the bacterial and the fungal. I hope you remember. The first thing about the fungal will be a trauma with a vegetative matter, with the animal tail, vegetative matter, okay, from a wooden twig. So these will be the history. What are the other findings which are seen in the fungal corneal ulcer? There will be a central defect with satellite lesions, and the central defect will have feathery margins, okay, and there will be grayish white dry looking ulcer, okay, and the hypopyon will be non-sterile. It will be non-sterile. Why? Because the hyphae, they cross the cornea and they are found in the hypopyon, so it will be non-sterile, and also it will be fixed because of the presence of the hyphae. What other differentiating features are seen in the bacterial corneal ulcer? The eyelid will be swollen. There will be more symptoms than the sign, and fungal corneal ulcer signs will be more than symptoms. Always we start the fungal corneal ulcer by the statement, signs more than the symptoms. Signs: feathery margins, satellite lesions, non-sterile hypopyon, and fixed hypopyon. In bacterial, there will be so many symptoms. Patient will be wincing in pain. There will be so much of the eyelid edema. Eye will be so red. There will be so much conjunctival congestion. But on slit lamp, there will be just an epithelial defect, and no many signs will be seen on the slit lamp. And the hypopyon in that will be sterile. The hypopyon in bacteria will be sterile. Next is, which dye is used in the anterior chamber of the eye? So, I don't know the exact wording of this question, but I think this much wording is enough to solve the question. Which dye is used in the anterior chamber? Why we use the dye? First, the question comes is, we use the dye in capsulorhexis. Whenever we want to do the capsulorhexis in the cataract surgery, we can use it in keratoplasty, especially whenever we want to stain the descemet membrane. Okay, in the posterior keratoplasties, when we want to stain the descemet membrane, we'll use it. In other surgery, we use it in the glaucoma surgery when we want to test the patency of the shunts. So these are some of the different surgeries or different procedures where we want to use the dye. But the most important being the capsulorhexis. So the dye which is used is the trypan blue. Okay. Why we want the capsulorhexis is, here you can appreciate, is because we want to leave the anterior capsule. We want to make a hole in the anterior capsule so that we can remove the nucleus, okay, and we'll keep the posterior capsule intact and we'll place the IOL, okay. So the cataract, especially the mature cataract, when there is no fundal glue, okay, they can ask you whenever what is the absolute requirement of the trypan glue. Does every cataract surgery requires trypan glue? No. Which types of cataract require trypan glue? Mostly is whenever there is no fundal glue. Whenever there is no fundal glue. In which condition there will be no fundal glue coming from the behind? It will be in the cases of mature cataracts. So whenever there are mature cataracts, there is no fundal glycine, we want to stain the capsule so that we can appreciate it and we can do the Rexus. So there we stain the anterior capsule with the help of trepan blue, and then our next process or the next procedure of the cataract surgery, next step becomes easier. Fine. So this is an image in the capsulorhexis stained with trepan. Fine. Okay, if you look at the other options, fluorescein. I hope you all remember fluorescein used in different procedures in the eye, and there is n numbers of from the anterior to posterior chamber in FFA. It is used in the diagnosis of the epithelial defects, used in Goldman applanation tonometers, used as a part of the BUT examination, that is the tear breakup time test. So I hope fluorescein you remember in tips. The steps or the procedures where it is used. Okay. So a man suffered an injury on the hand, and after this the blood collected around the eyes. Which structure attachment causes this condition? So again, as I said, these are not the exact statements of the question, but what I get from this question is they wanted to ask that why whenever there is periorbital edema and ecchymosis are happening, which layer of the eyelid is involved. Okay, so that is how I understood this question, and I'm trying to solve this question also. So which structure attachment causes this? We'll come to this point only. But before that, I think we need to summarize. If any one of you does not remember, the layers of the eyelids are pretty enumerated. So there are 7 layers in the structure of the eyelids. Okay, these are 7, starting from the skin obviously and ending on the conjunctiva. Okay, so below the skin there is subcutaneous areolar tissue, that is a connective tissue layer. Fine. Then is the layer of striated muscles, that are orbicularis, oculi, and the LPS muscle. Okay, and again leave the 2 layers, and the second last layer becomes the layer of non-striated muscle. Which muscle is this? That is the Muller muscle. And between 2 is the one is the below the muscular layer is the submuscular areolar tissue, and is the fibrous layer, which we commonly know by the name of tarsal plate, lies in this layer. Okay. Now out of these 7 layers, submuscular areolar tissue, this layer is basically connected to the subaponeurotic layer of the scalp. Okay, it is connected or it is communicating to the subaponeurotic layer of the scalp, which is what? The subaponeurotic layer of the scalp is what? It is a dangerous area of the scalp. I hope all of you remember as the dangerous area. So any trauma in the head, basal skull fractures, trauma to the head, the blood, the abscess, whenever there is abscess or there is blood, it can travel from the scalp, from the head region, from the scalp to the eye, because there is communication between this and this layer. So which layer is involved in periorbital edema, periorbital ecchymosis will be the aponeurotic attachment, that is seen with the scalp and the submuscular plane of the eyelid. So the answer to this question will become this, if this is the statement of the question. Fine. And this is a pictorial diagram of the eyelid structure. I hope all of you remember this. Fine. So next question is, in which type of cataract surgery is suturing with nylon 10-0 is performed? So again, a very straightforward, easy question, clinical based question. So I think this is a very easy, everybody must have answered it right. Nylon 10-0 suturing is done in conventional ECCE, flat phacoemulsification or the SICS. If you want to quickly revise it, we can summarize the types of the cataract surgery. So I think that will be more clear. We can broadly divide the cataract surgery into intracapsular and the extracapsular. Why it is extracapsular? Because we are not removing the posterior capsule. So intracapsular, it is an obsolete surgery. Here there were the limbal incision was given from 9 o'clock to 3 o'clock, which was around 180 degrees. So obviously we need to suture is this. Okay, this was my limbal area and we used to give the incision at this area from 9 o'clock to 3 o'clock, that is 180 degrees. So you have to suture it. Fine. Again, ECC can be conventional, or the further advancement which we're seeing are the small incision cataract surgery, manual small incision, phacoemulsification surgeries, and the latest one is the femtolaser assisted cataract surgery. In conventional, we used to give the incision from 10 o'clock to 2 o'clock. Again, it was a limbal incision. So again, we have to suture it. While the rest of these, SICS surgery, phacoemulsification surgery, and femtolaser assisted cataract surgery, they all are self-sealing incisions. They are given in these type of surgery. In SICS, what we do is we make a corneoscleral tunnel 5.5 to 7.5 millimeters approximately. In phaco, what we do is we do a clear corneal incision in both phaco and flat. Clear corneal incision. They are varied depending upon the area where you are, depending upon the surgeon. They can vary from 1.8 to 2.8. Very minimal incision cataract surgeries. So three of them, they are the self-sealing. Okay. So in this conventional extracapsular and intracapsular, there were the limbal incisions. In SICS, there is corneoscleral tunnel. Phaco and flax, there is clear corneal incision. What is flax is nothing but just the femtolaser second is doing the capsular access for us which we are doing the manual capsular access. The femtolaser is going to do the capsular access. That is the main difference. Okay. So the answer to this question will become the conventional extracapsular cataract surgery, where we have to do the suture. Okay, we have to do the multiple suturing of the incision with nylon 10-0. And which type of suture is used? You can remember it. That is nylon 10-0 suture. That is a type of a non-absorbable suture. Next question was yoke muscle for levo depression. So a very quick way to solve these types of question is, firstly, split the option which is given, levo depression. Levo will make eyes, levo depression, left side depression this. So down and out position of the left eye, this is levo depression. So we know that which type of muscles. For these types of question, you need to remember the fact or the statement which we always discuss. Thus, rectiles, they are the better elevators and depressors in abduction, and obliques, they are the better depressors and elevators in adduction. Okay, rectiles in abducted position, they are the better elevators and depressors. Obliques in adducted position are the better elevators and depressors. So levo depression is left side is looking outwards and downwards. Okay, so that is, it is abducted. So which muscle is depressors in abducted position is the rectile. So which will be the option? Left inferior rectus. And we know that to find out the yoke muscles, just flip the option. So if the option is left inferior rectus, just flip it. It will be right superior, sorry, oblique. So the answer will become right superior oblique. That is the main quick tip to find out the yoke muscle is just flip it. And we know that the yoke muscles are what? They are a group of muscles from each eye. So the other has to be from the right eye. Okay, so just flip it and you get the yoke muscle, simple for the exam point of view. But if you want to revise it, if you want to make your concept, this is an image, that is how you have to start. This is the primary gaze, this is the elevation, this is the depression. Fine. This is, if we are talking from the patient's points of view, this will be his right side. So this is will be dextroversion. This will be levoversion, dextro elevation, dextro depression. It will be there. This is levo elevation, and levo. So we were asked about the levo depression. So this is his right eye. This is his left eye. His left eye is moving outwards and downwards. Which muscle acts in outward and downward is the recti muscle. So, and depressor is inferior rectus. So it will be left inferior rectus. Which muscle? His right eye is moving medially and down. Which muscle acts as a depressor in the medial position? In the medial position, which muscle is the elevator and depressors? They are the obliques. Out of the obliques, which is a depressor? It is the superior oblique. So the answer will be right superior oblique, and that is a trick to do find out the yoke muscle is just flip it. Okay, if the answer was right superior oblique, it will become left inferior rectus. Okay, it was right inferior rectus. If any options is right inferior rectus, just flip it. Okay, it will be left superior. That is how we find out the yoke muscles from the exam's point of view when we want a quick answer to the question. And this is how you make a concept to find out the yoke. Okay, and this is how we diagrammatically represent our muscles. I hope all of you remember this image. You must remember this image to solve all your questions. Okay. Drug used in refraction in a child with squint. Okay, so I don't know if the age of the child was mentioned or not. Otherwise, normal dictum which we study is in preschool age group we use atropine. But here, if the option was not given, then we have to tick mark. If the age was not given, we have to tick mark atropine only. And one thing about atropine which you always study is it is used in the ointment form and not in the drop form. Otherwise, it will be absorbed from the nasolacrimal duct and can give systemic side effects. So it is used in atropine ointment. How? TDS for 3 days, and effects last for 25, which is used in adults, is only a mydriatic and not a cycloplegic. Okay, and why we are using drugs in refraction in child with squint? Why we are using wet retinoscopy in the patients with accommodative esotropias, exotropias? We have to look out for the refractive error, especially if there is a case of accommodative esotropias. We have to look out for the uncorrected hypertropia. Okay. Next is blurring in papilledema. Only these 3 words, mainly the 2 words I found in the question. I don't know what was asked in the question, but from this statement, I can only tell you is in papilledema, there is blurring which is seen. That is the transient blurring which is seen in papilledema. There is no effective vision. There is no loss of vision in papilledema. Okay. So vision is not lost in papilledema. There is just transient blurring which is seen. Loss of vision, defective vision will be there when papilledema, it is a long-standing papilledema, it turns into optic atrophy. Defective loss of vision will be seen in the patients of optic neuritis, but it is not seen in papilledema. There is only transient blurring which resolves on its own when the papilledema will resolve. Otherwise, there is no loss of vision in papilledema. So these were the questions from the OPHTHAL session, and I hope all of you were well satisfied with these questions. If not, You can take a a lesson from them. You can learn them. You can use in your next examination. You have to appear for your NEET examination, for INI examination, and I hope there these questions will help you and they can make your concepts clear. And I hope the session was make successful in making some concepts if they were left behind to make them clear. Otherwise, if you knew them, then it is very good. If you did not know them, do not lose your heart. Just start now again and make your concepts clear. Read every topic, previous year questions by heart because they are repeated very oftenly, and important topics they are repeated very oftenly. So just keep on working hard. Okay, that is all I can say, and you have to prepare for the NEET and INI, and all the best for that also. So this was the session for FMG recall. Thank you, and I hope you all did great.